only does it improve mortality, it improves their quality of life. And so, you know, from my standpoint, I was extremely comfortable with it. And I honestly feel like a weight was kind of lifted from my shoulders by Dr. Botha. And so that's what I think.
Terrific. Dr. Fitzke?
Well, I was excited. Of course, all of us that go into surgery are excited about being able to separate the patient from their disease. And carcinoid is a very rare tumor, as everybody has alluded to at this point in time, and there are no fantastic, miraculous medicines that you can give carcinoid patients to absolutely obliterate the tumor. So anytime you can separate that tumor from the patient from a surgical standpoint, it's obviously very fulfilling. Now, because there's so little known about carcinoid, some of us do become a little pessimistic about advancing the amount of surgery that you do for somebody with this particular type of disease. But based upon his research and his expertise, we were very excited that we had somebody with his expertise in the area that could potentially even approach a novel procedure such as this. And so it's very exciting to be in an area where you have those resources available to you.
That's wonderful. And so turning back to you, Dr. Botha, so it sounds like, do you want to describe a little bit more about the details of the procedure? It sounds like it's a two-step process, is that correct?
That's correct. So you have a patient with metastatic disease in the liver, which is obviously not resectable by conventional means, which would be either a left lobectomy or a right lobectomy or an extended resection on one of those two sides. There's tumor obviously throughout both lobes of the liver, and clearly by taking one half, you're going to be leaving tumor behind and probably not impacting long-term survival if tumor is left behind. So the goal of this is to remove 90 to 100% of macroscopic tumor. And at the outset, you plan on going in and taking either from the left or the right lobe. So let's separate the liver into two halves, a left and a right. You attack the one lobe first and remove all disease from that lobe of the liver. And really what it is making that lobe into Swiss cheese. It's just taking out tumors wherever you see them and clearing out what is going to be your future liver remnant. So you make sure that you get all the disease you can out of that lobe of the liver. The remaining lobe is still packed full of tumor. You then, either in the operating room, ligate the portal vein to that section that still has tumor in it. And what that will do is stimulate hypertrophy of the remaining side that you've just cleared out of tumor. Or I can have one of my radiologists do what we call portal vein embolization, and it's percutaneously stick a needle into the liver and actually block off the blood supply for me to that side. And that stimulates our future liver remnant to grow. Once we've allowed it to grow within a period of 6 weeks to 3 months, we then rescan and make sure that it has grown and that there's still no residual tumor within that lobe of the liver. We then go back for our second stage and remove the remaining portion of the liver that has still got tumor in it. So with that two-stage procedure, you've removed all the macroscopic disease from the liver and you've left a liver remnant with no tumor in it. And that's allowing the capability of the liver to regenerate to work for you. The beauty of carcinoid is because it's slow growing, you've got the time to do that without the risk of metastasis occurring. That's why it's difficult to apply to other tumors such as colon cancer, liver cancer, is that 6 week to 3 month period that you need for the liver to regenerate, you're at risk of tumors metastasizing, tumors growing and becoming uncontrollable. So neuroendocrine tumors that's why this is a particularly good procedure that's suited to these tumors, because they're slow growing, and it gives you the time to be able to do that.
Interesting. And so before we move to the next step, what neuroendocrine tumor patients would you recommend this procedure for, this liver procedure for?
Well, any, in fact. It's not restricted to carcinoids. Pancreatic neuroendocrine tumors that are metastatic to the liver, again, the same thing can be applied to any of them because the majority of them are slow growing. Those that secrete, those that don't secrete. Again, you're going to change the symptoms, you're going to improve their quality of life, and you are going to improve their long-term survival by being able to not only debulk, but with the goal of actually resecting all macroscopic disease. So it's patients who have the primary is controlled or has been resected, there's no residual tumor at the primary, and there's no metastatic disease elsewhere other than the liver. There's purely just liver disease within the liver. Those are the patients we can be aggressive with, no matter what the endocrine tumor is. Whether it's a gastronoma, whether it's a pheochromocytoma, whether it's something from the something else from the pancreas that is metastasized, or any other gut neuroendocrine tumor. So
I see. And then for the liver presentation, what do you look for to determine whether this patient should undergo this procedure?
right, it's the goal is visualizing a future liver remnant that's going to be free of tumor. So you've got to be able to, at that first operation, be able to remove a tumor from a lobe that you're going to preserve. And you've got to be able to show yourself that you can get all of that out and have a lobe of liver that is free of tumor.
I see. And what would you see that would make it difficult for the lobe of liver to be free of tumor?
Again, it's just multiple tumors in difficult places to get at.
Okay.
Again, near to vital structures, at the portal bifurcation, the hepatic artery bifurcation, where the hepatic veins are going in. Those are what's going to make them difficult to get out. If they're wedged into blood vessels that you have to, between blood vessels that you have to keep, between bile ducts that you have to keep and preserve to allow the future remnant to function normally. So that's what's going to make it difficult and rule patients out of the procedure if we're unable to clear that future liver remnant.
And can you see all of that on a scan before you go in?
Correct. That's how we make that determination.
Okay.
Obviously, patients get the routine imaging studies that most neuroendocrine tumor patients get in terms of octreotide scans, CT scans, MRI. We've become very impressed with the MRI scans for neuroendocrine tumors. They're particularly good at detecting them, particularly good at showing us where they are, what their relationship to vital structures are, more so than CT scans in our experience. We have a superb dedicated abdominal MR radiologist here at this hospital that is a specialist in liver MRI imaging. So I've become very impressed with MRI as a technique to be able to aid me in having a roadmap when I'm in the operating room, knowing what I'm going to be looking at. Obviously, in the operating room, we do use intraoperative ultrasound as a further technique to be able to localize where the tumors are and try and enable us to remove them. We could, turn back in the operating room and say, no, we found something in there that prohibits us from doing this. But again, that hasn't happened yet, but it may in the future.
Okay, and so then you were in the middle of describing the two-step process.
Right, so once you've allowed that liver remnant to grow, the second stage is going in and removing the bulk of tumor in the remaining just taking off the entire lobe with all the tumor in it. So again, it is 2 operations. It's a big deal. They're 2 major surgeries. 2 liver resections is a lot to ask anyone within about a 3 or 4 or 6 month period of time. But so far, again, I've been impressed with the patient's ability to tolerate it. Most of them have done very well. Fortunately, I've had no one with carcinoid heart disease yet that would complicate liver resection. But again, it's stuff we know what we're looking for in patients with this disease. We look for it beforehand, and hopefully we're as prepared as anyone could be in operating on them.
And what kind of complications, just to detail them specifically, would patients have to be aware of before undergoing these procedures?
Okay, well, carcinoid patients in particular are always at risk of a carcinoid crisis in the operating room, and that's something we obviously try our best to avoid and are well prepared for that. And that's unique to patients with carcinoid. Carcinoid heart disease as well results in unique complications and makes bleeding a big problem in liver resections. Again, we try to be well prepared beforehand. But then unique to liver resection itself is you're cutting across an organ that's extremely vascular. Bleeding is always a problem in the operating room. These days our techniques and our abilities to control that are very good, so it's become less of a worry. In the post-operative period, again, because you're cutting across a piece of liver, you're cutting across bile ducts. Bile leak from that cut surface is a 1 out of 10 chance that you're going to get that problem, but it's usually benign, easily controlled, and easy to fix without having to go back in the operating room. Then any complication attendant to any other major abdominal surgery, wound infections, pneumonias, urinary tract infections, blood clots developing in the calf veins, those are things we're acutely aware of and make every effort to prevent. So in terms of the uniqueness, it's just a big operation. The risks in terms of bleeding are there, but we, again, take every effort to, we know how to deal with this now, the techniques and technology that's available to us.
And so how did the 3 of you work together after this procedure to deal with any complications that arose?
Well, I'll just start quickly and say
Okay.
that, I mean, patients are in hospital for a period of time, and I'm able to discharge them to the care of Mike, who I know is going to take care of most of what, most everything that I, ask him to do. And again, the ability to email me